Okay, we had a little technical difficulty, so this is the second portion of the CIRS diagnostic talk. I was speaking about the epidemiology and the risk to the population, which is inherited based on poor antigen presentation. These are HLAs, alleles on chromosome 6, that many people have, and we know that it's about 20% of the population. So as I'd mentioned before, in the U.S., about 40 million people, and it makes individuals vulnerable, basically, to all biotoxins. And there are dozens and dozens of biotoxins, and that includes Lyme and tick-borne illnesses, COVID, algae growing in bodies of water, all sorts of things. So, what are the diagnostic challenges then for dealing with CIRS? Number one, we always ask the question, do they meet criteria for CIRS? And I'll talk about, what that is. Number two, does this patient suffer from a tick-borne illness? That's harder. There's a lot of tests that are out there. I don't think a lot of them are very good, quite frankly. I'll show you how I get beyond that with some of our genomics. And then finally, if the patient does not have a mold exposure or tick-borne illness, what is the exposure? Well, guess what? I'm going to blow your mind with some new data on what might be the most common biotoxin that we're finding in our patient population, and it's not what we thought it was. Okay, so all new data, very exciting. So there's at least 30 entities that make illness from inflammation. So beta-glucans and mannins and spirocyclic dryamines and lipopolysaccharides, actinomycetes, hypofragments, cell wall fragments, the list goes on. There's, oh my gosh, Dr. Heyman, I don't know what any of this stuff is. Well, when you step back and you say, well, what really makes people sick? It's 80% of the time or more, it's from a water damaged environment. So it's usually our living spaces. Okay. So keep that in mind. The rest, the other 20% or so, is, it's pathogens, it's other environmental biotoxins like algae, for example, that grows in bodies of water. It's things that we inadvertently ingest in our diet, that are organisms as well. Ciguatera being the classic for that. But there's lots of these that are out there, and that kind of sometimes makes it hard to identify. We have a wealth of data on these biomarkers, and we know what a lot of them are. In addition to the sort of standard assessment tools that we use to identify the CIRS patients, then as a reaction to these biotoxins, the question then becomes, what else do we have at our disposal? And it turns out that there are a variety of physiologic changes that we can uncover and identify if you do a very precise analysis. There's a profound effect on the cardiopulmonary circuit in this illness. Why? Because capillaries constrict. And when capillaries constrict, there's poor blood flow between the heart and the lungs and out to the peripheral tissue and up into the brain and other vital organs. This is a feature of the illness. So we can see a mild pulmonary hypertension. We can see stretching of the right atrium, and therefore an irritation to the sinoatrial node, tricuspid regurg, palpitations, shortness of breath, air hunger, and even more profound alterations to the lung tissue. So we can see restrictive lung disease or interstitial lung disease, as well as changes to the brain and alterations throughout the gut. So we can see, again, the dysautonomias, and ultimately abnormal transcriptomics and proteomics, and the presence of the HLA, that 20%, which we can measure, and alterations in the inflammatory process in the brain, which we can measure. And all of this has to be taken care of. We have to deal with the biotoxin if it's present. We have to turn off the inflammation, and we have to restore normal genomics, okay, which in turn fixes the changes in the brain. So, are there differences in the body's response, as far as we can tell, to the various biotoxins that are out there? Nope, as far as we can tell. So, there are some subtle things, but in general, in terms of symptoms and the blood markers and proteomics and all that, it's all the same. We can see some differences on the genomic level, that there's certain patterns of gene expression that point to different different exposures or different features of the illness, which begin to subsegment patients. But broadly speaking, one of the things that my patients love to do is they say, oh, well, I know what the symptoms are for Lyme, and I know what the symptoms are for Bartonella, and I know what the symptoms are for Babesia, and those symptoms over here are for Lyme disease or for mold exposure. Nope. Patients can't tell them. We've tried. We've tested them. We've actually given them symptom surveys and asked them to determine what is your biotoxin of choice. Can't do it. Even though there are symptom lists that apparently go along with various exposures. The body has this kind of broad, uniform way of reacting to these things. And yes, there are there are variations on that theme within that broad response, but it doesn't correlate to the biotoxin per se, as far as we can tell. So, what are the tools that are at your disposal to begin to measure this? Well, we can do a symptom cluster analysis, and I'll show you what that looks like. We can do PFTs and diffusion capacity to show that there's restrictive lung disease. We can do EKG with echo to identify whether or not there's pulmonary hypertension present. We can also do the capillary constriction, loss of VO2 max, and loss of exercise tolerance. And we see changes on the visual contrast test, which is a measure of inflammation in the brain. NeuroQuant, which shows injury to the brain. Transcriptomics, which that's a basis of our research to demonstrate abnormal patterns of gene expression. And then we want to show that our treatment interventions are changing all of these indices for the better. And they do. They do. So here are those symptoms. There are 37 of them. We break them into 13 clusters or categories. So interestingly, symptoms kind of group together. And our diagnostic criteria is that if patients have one symptom in 8 of 13 clusters, there's a high likelihood that they have CIRS, especially if they fail the visual test. They fail the visual test and they have one symptom in 8 of 13 clusters. We have a 99.6% accuracy rate of making the diagnosis. So if you really look at this list, fatigue and headaches and aches and pains and digestive issues and shortness of breath and cognitive decline and mood swings and temperature dysregulation and numbness and tingling and lightheadedness, and you say, oh my gosh, that's all my patients. It is. It is. And in addition to that, I would say one of the biggest ones, which, really is sort of profound and I never, I think, fully appreciate is weight gain. When patients come in and they say, I've gained 30, 40, 50, 60 pounds, I have no idea why, and I can't get it off no matter what I do exercise wise, no matter what I do nutrition wise, it's really frustrating. It's defeating. I start looking for CIRS. I start looking for exposures. So if they have, fatigue, brain fog, and weight gain, I'm finding it CIRS until proven otherwise. Because of course you already think, well, no, it's got to be food sensitivities or hormonal imbalance. It's got to be the thyroid, or no, it's got to be menopause, or whatever, or low testosterone. I'm finding all those things are part of this illness complex. So you'll find those abnormalities, but underneath of that, I'm finding it CIRS. So as a trick, then, I'd say if you're at all suspicious, you have patients, fill out the symptom survey, see where they are in their, illness complex, and you commit yourself to learning this process. As I said, we spent many years looking for the blood markers that underlie this illness. Where were they hiding? They were hiding in the innate immune system, not a place that clinical medicine tends to investigate very much. CRP, SED rate, ANA, all that sort of stuff. That's the domain of the rheumatologist. That's the domain of autoimmune processes. That's the domain of cardiometabolic inflammation, but not innate immune function. And so every time we measure these patients, we go, oh my gosh, we don't find anything. They're really sick, but we can't find anything. But the labs are essential because they establish a baseline, they help guide therapy, they determine the steps of treatment, and they get us to the last step of treatment, the very special therapy called VIP. And VIP stands for vasoactive intestinal peptide. I'm going to be talking about that quite a bit. VIP, vasoactive intestinal peptide. But even normalizing the labs will not ensure cure. Why? Because we still have some underlying abnormal genomics. Okay. So, yes, we get rid of the biotoxin. Yes, we normalize their lab values so we know that their physiology and proteomics and all that is going back to normal. This is almost kind of the domain of the functional practitioner, right? We do the nutrition and the nutrients and the hormones and all this sort of stuff. And we know an aspect of this illness improves, but we also know there's a residual part of the genomics that will not improve no matter what tricks you throw at them. You got to know what you're doing. There are steps in the process. Do not skip steps and go in the order. There's a reason why we do what we do. So here I have in great detail, how do I make the diagnosis? How do I know these patients have a biotoxin? Well, we give them the symptoms and then we order the lab evaluation. We have them do the visual contrast study, and I'll show you what that is. If they fail the visual test and they have 8 of 13 symptoms in the clusters present, you've made the diagnosis. Do a good H&P, do an exposure history. Now, how do I verify? Well, all those labs start coming back, all the objective markers start coming back, and now you've had this discussion with the patients. Do they have a known exposure? Sometimes they do, but sometimes they don't. They can't remember. Okay. We also want to rule out other causes for their symptoms, of course. And we determine whether or not they have positive symptoms in 8 of the 13 clusters that I showed you. Now we start reviewing the objective markers. Did they fail the visual test? Do they have presence of the HLA? Do they have abnormal proteomics, elevated MMP9, alterations in ACTH cortisol ratio or ADH osmolality, a low MSH, abnormal VEGF, abnormal C4a? I'll show you what those are. And then confirmation in 2 of 3. Do we have symptom improvement with treatment? Are they able to pass their visual test with therapy? Do we have resolution of laboratory values? That confirms it. Okay, so we have tiers. We say, do they have a known exposure? Ruled out other causes. Do they have likely symptoms? Yes. Do we have a variety of findings? We need at least 3 of 6 or more. Okay, and we confirm with our treatments to say, how are they getting better? Either feeling better, passing a visual test, or we see resolution of their labs. In addition to that, we want to do some diagnostic refinement. What's the biotoxin? Is it a tick-borne illness? Is it something growing in the home? Can we do some of the fancier testing if we have access to it, like cardiopulmonary, to show loss of VO2 max or exercise tolerance? Can we do a brain MRI with neuroquant, meaning that we can identify the structural alterations in the brain? Do we see some abnormal transcriptomics, meaning abnormal patterns of gene expression? So, what about this visual test I keep mentioning? What is this? Well, it's a very easy test to do. They can do it online on surviving mold. It's well validated. It's been used for, 40 years or more. It's developed by the military for fighter pilots. And it was meant to determine whether or not an individual had had an exposure to a biotoxin. So this notion that we'd have a cheap and easy and reliable tool to say, hey, this patient has a brain on fire. They have a cytokine storm. And guess what? That inflammation affects the blood flow, the constriction of capillaries to the back of the eye. And what that in turn influences is contrast capacity or color discrimination. And what that really means is the ability to see an edge. And so as the patient has a harder and harder time with their contrast capacity, they start failing the test. It's a wonderful tool. It's amazingly reliable. It's dirt cheap. I use it to help make the diagnosis, and it's the first treatment goal of turning off the fire in the brain, as demonstrated by passing the visual test. Now, I would say about 9% of the population can beat the test no matter how much fire they have in the brain. Okay, so just note that if they pass the visual test, it tells you something less. If they fail the visual test and they have 8 of 13 symptoms, 99.6% accuracy rate of CIRS. They've had an exposure, it's ignited the fire in the brain, they're failing the visual test. I can't say enough about how important this visual test is. So easy to do, survivingmold.com. They do the test in 10 minutes and you get an answer. It says pass or fail. Here we have, and this is our data, Lyme patients that we treated, and what it shows is 20% of them failed the visual test after proper therapy. So there's that number again. That's what this shows. This is what the results look like, on survivingmold.com. Now, there's other ones online. Don't use them. There's something called vcs.com. It's not reliable. I want you to use surviving mold. And here's a patient who missed this. So, and what are they going to be presented with? They'll be presented with these circles with little lines inside. They're gray. And the lines are pointed straight up and down, left or right. And the patient needs to determine which way they think the lines are pointing. They're going to have a harder and harder and harder time even seeing the lines. Okay, so this patient didn't do so bad. I've seen far worse. I've seen far worse. but they failed. So there's these very sophisticated algorithms that sit behind the test, and it tells you pass or fail. And again, our first treatment goal, like once you get beyond the diagnosis, say, yep, it's a biotoxin patient, they have CIRS, this abnormal reaction, it's ongoing. We think it was from a home 10 years ago. Yes, they've had fatigue and brain fog and aches and pains for all that time and never turned off. We think we're okay on the biotoxin side, but they're failing their visual test. So we got to get them going on therapy. And our first treatment goal is to use a certain kind of clinical strategy to get them passing the visual test. Okay, that's our first goal. I don't care what the labs show. I don't care what any of the other fancy tests show. Our only and first goal is to get our patients passing the visual test by reducing the fire in the brain. Now, remember, all this is instigated by those HLAs, and here are the alleles. Now, this is kind of an old slide in terms of we used to think out of the 9 or so HLAs that are present, you know, different HLAs had different characteristics. Some were multi-susceptible, meaning that if a person had these alleles, they could be vulnerable to any biotoxin. And then, we thought, well, there are other alleles that are specific to one exposure or another. I don't think that's true. Most of us don't think that's true anymore. I think they're all multi-susceptible. I don't think any of them are dreaded. Some people talk about the dreaded gene, the 4353B. I don't think that's true either. Okay. If they're present, they confer some vulnerability with poor antigen presentation, which means they get stuck in the innate immune response. The genes start to change, CDR1, CDR2, triad 2, triad 4. So, what is this proteomic? So we get beyond the visual test, we get beyond the symptoms, we're beginning to think, yep, this is a biotoxin patient. What are those blood markers that I keep mentioning? It took us forever to find that are coming out of that innate immune system. Well, let's get into that. Let's get into that a little bit. So what does that look like? What is this pathway that begins to articulate how patients remain, first start sort of expressing those markers that I've mentioned? And what does that look like in terms of the end clinical response? So we have a biotoxin patient, and you can see in that upper category this HLA susceptible. Okay, so what that means is that the brain ignites into this storm of cytokine production. And those cytokines not only produce sort of that uh, uh, systemic illness pattern, but they also begin to damage the leptin receptors on the posterior hypothalamus. And this starts off a cascade of events that not only is one of the precipitating factors for obesity, which doesn't respond to exercise and diet, but also the entire hypothalamus is now altered. And this notion that we begin to see changes in the neuropeptides that are produced from the hypothalamus becomes profound. And in particular, we see changes not just in levels of VIP and arginine vasopressin, but maybe most importantly, a hormone that you guys probably never heard of, melanocyte stimulating hormone, or MSH for short, a critical compound that we can measure in the blood. It turns out that over time it drops. It goes lower and lower and lower. And when that happens, all sorts of bad things occur. Why? Because MSH is one of these sort of dominant master control hormones that affects a variety of processes in the body. So it helps to produce melatonin. So patients in turn end up having poor sleep. It also is supportive of endorphin production in the brain, so patients tend to have chronic pain in this illness. MSH is also responsible for tight junctions in the gut. So guess what? When MSH levels fall, the gut becomes leaky. The gut gets leaky. So no wonder these patients have issues in the gut. In addition to that, it supports white blood cell production. It also supports cortisol and ACTH, so they lose stress resiliency. It upregulates aromatase, so you get this overconversion into estrogens, and we see reduction in ADH. So when ADH levels fall, which is antidiuretic hormone, guess what? Patients become intravascularly dry because the kidneys are not resorbing water. So now they're hyperconcentrated, they get lightheaded, they get POTS. So when ADH osmolality goes out of whack, they have these dysautonomias related to vascular incompetency. And then finally, we have one of these little odd findings, which is really important to address, which is a staph bacteria that starts to notably become present in the deep nasal passages. So when MSH levels are low, this staph can begin to grow. And we find it in the back of the nose. And if it's present, it's a very smart bug. It doesn't cause sinus symptoms. It doesn't cause sinusitis. But instead, what it does is it um, produces something called a paletoxin, which is distributed throughout the tissues in the brain. It just makes everybody feel worse. And we have found its genomic imprint too. We know that it affects the what we call mitoribosomes. So there's a fancy term, mitoribosomes. These are the ribosomes in the mitochondria that are responsible for protein assembly. In addition to that, we can see changes in the, and let me see if I can move this. Oop, that didn't work so well. Well, okay, maybe that works. Um, so what we can see are changes in cytokine levels. So that affect everything, that really affect hypoxia inducible factor. And what that does is that in turn stimulates VEGF and TGF beta 1. These are two markers that we measure. So we're measuring MSH, we're measuring cortisol, ACTH, we're measuring reproductive hormones, we're measuring ADH osmolality, we're swabbing for MARCons, and we're measuring VEGF and TGF beta 1. These begin to affect everything from the pro-inflammatory state to capillary constriction. Profound changes here, profound. In addition to that, we begin to see anticardiolipin antibodies, drop in T regulatory cells, anti-gliadin antibodies because of the leaky gut, but also production of these very important compounds C4A and C3A. Now, there's only one lab in the United States that really, runs that set of samples well, unfortunately. So they can be hard to get, but if you can get them, they're great because when the C4A goes up and the C3A goes up, we know that they're having issues. When the C4A is high, that's a good indicator. When the C3A is high, that's usually from bacterial membranes. We start to think about tick-borne illnesses. And then finally, we can measure MMP9, which is produced as a kind of a bridge between the innate and adaptive immune system, as well as Pi1 and the rest. So when you look at this, say, oh my gosh, Dr. Heyman, I mean, what a disaster for physiology. I mean, I'm kind of seeing everything here from, brain inflammation to aches and pains and sleep to stress and infections and the gut and cardiopulmonary issues? The answer is yes. You're going to have to absorb this slide. This is a really important one. It begins to articulate the proteomics that we measure. Okay, and that's important. So let me move this back. I know it's going to change things a little bit, but that's okay. Here we go. So what I've done for you is I have put in here what our normal ranges are for these various markers. So when we measure VIP, this is the range that we'd like to see. When we measure MSH, this is the range we like to see. And I've given you the full descriptions. I don't want any guesswork from you guys. I want you to really understand, what does Dr. Heyman measure? What are his ranges? These are all the proteomics. These are the blood markers. Took us a long time to find. TGF beta 1, C4A. Now, the C4A is interesting. If you notice, the upper limit's 2830. And what we have found is that if you have a proper C4A done and it comes back above 10,000, it almost always indicates a reaction to a water damaged environment. So, with that being said, there are certainly patients who, don't react to, or they have a lower C4A, and it is to a water damage risk. So they might be 5,000, 6,000. Okay, but if they're above 10,000, it's to one of their environmental spaces. Okay, so this marker can be really helpful if you can get it done properly. We can see some of the anti-gliadin antibodies go up, abnormalities in ACTH, cortisol ratio, VEGF. VEGF goes up above normal in the early stages of the illness, and then it falls below normal in the later stages of the illness. Anticardiolipin antibodies, ADH osmolality, so this is where they get intravascularly dry. What you'll often see is a very low or undetectable ADH, but an osmolality like 295. So they're hyperconcentrated and the brain is not reacting. It's not telling the kidneys to hold on to water and get more hydrated. MMP9 is a pro-inflammatory compound. It degrades connective tissue in the extracellular matrix, so it's been linked with arthritic processes and atherosclerosis. Leptin starts to go up in these patients, not uncommon again because the cytokines injure the posterior hypothalamus. So here are some of the labs that I like to draw And I just want to kind of show you what they actually look like, at least in the way that they're reported for me. Now, I know you guys probably have a very different way of sort of reporting. These are our normal values. And so here's a normal CBC, right? So normal white blood count. Say, oh, well, there's no immune issue here. Well, there is. There is. So here's another good example. So ADH osmolality, normal. So zero point 0.8 and 286. No anticardiolipin antibodies. Okay, fine. But guess what? The MMP9 is high because it's 501. It's above 332. Now, the other thing you'll notice is that sometimes the ranges that are on a reported lab are different than our ranges. Well, we've verified or validated our ranges. So, I know for certain that anything above 332 is too high for MMP9. So click a box saying, okay, let's say it's a patient who failed the visual test. They have a lot of symptoms. Now we have at least one marker that's abnormal. Remember, we need several. Up, TGF beta 1 is high, 7100. Now we have two markers. In addition to that, here's another Lyme test that was negative. We also see clotting factors. So, and we'll talk about this in the future, but we can see not just anticardiolipins go up, but D-dimer, von Willebrands, a whole variety of stickiness that occurs in the blood. This patient was okay. But if you notice their MSH is low, it's 20. Anything below 35 is too low. Now, the stated range is 0 to 40. You say, well, Dr. Heyman, that says the normal 0 to 4. Well, it's not normal. Anything below 35 is too low. And look at this. Look at this. The C4A. The C4A. 17,695. Now remember, what did I say? Anything above 10,000 is pathognomonic or specific for exposure to a water damaged environment. That's what this patient has. That's what this patient has. So now we know they failed their visual test. They have a lot of symptoms. They have an abnormal MMP9. They had an abnormal TGF beta 1. They had an abnormal MSH, and they have an abnormal C4A. Say, yep, now I know it's a biotoxin patient. They met the case definition or criteria. And even better, one of the labs came back and it gave me even greater detail. Okay. So, what other tools do we have at our disposal between the visual test, the symptoms, and the proteomics? Well, let's go to the brain. We started asking the question in 2014, are there changes in the brain that are characteristic to this illness? And the answer was yes, but the answer was also surprising. So, when you listen to this patient population, they almost always complain about short-term memory loss, poor concentration and focus, brain fog. We thought, okay, we really need to measure the brain. We know there's going to be poor capillary blood flow. I'm sure there's some sort of tissue strain that's going on. But do we have a tool that allows us to measure the brain architecture in great detail? So this is not a functional study, it's a structural. And the answer is yes, it's called NeuroQuant. So this is volumetric brain imaging. So we can look at 11 centers in the brain by size or volume. It's very inexpensive. It's just a software program. The company, licenses it out to MRI centers all over the place. It's reliable. It's been validated. It originally was designed for Alzheimer's and Parkinson's to look at the hippocampus and the basal ganglia, but we can look at just about any structure in the brain and know. So we also understand that when there's sort of a brain injury, there can either be interstitial edema, so increase in volume, or atrophy or pruning, meaning decreased volume. So, and I'll get into atrophy and pruning. So this notion that there's a pattern of injury that emerges in the brain. Now, we thought our hypothesis was that there would be a single pattern correlated to CIRS, and there wasn't. There wasn't. And it actually better correlated with the genomics. So what's that pruning I mentioned, this sort of, decreased volume? Well, pruning is good because it means that when we insult a neuron, the dendrites retract. And when they retract, basically it's protecting itself. But if you stop the threat, guess what? The dendrites rebud and they regrow and they get new volume so they can heal. We didn't realize the brain had this ability, but sure enough, there is dendritic pruning. On the other hand, there's also atrophy. So unfortunately, we can kind of scarify an area of the brain and it can't heal. Now, we can't tell based on NeuroQuant, right? Because it's just a volumetric. We see volume loss or small areas. Doesn't tell us. Not until we treat do we know if the brain's going to go back to normal. So here's a typical slice. We then segment it, and then the computer algorithm begins to assign values to different areas of the brain. And what we look at are 11 centers by percent size or volume. And we start scoring these. So we have a set of algorithms. You can go to survivingmold.com if you're able to order a neuroquant, put in these numbers, and you'll get the score. And what we've noticed, and this is what was surprising, is that there was one set of changes for water damage building. There was a different set of changes for Lyme. There's a different set of changes for stress, that the neuroquant sort of revealed the underlying issues. That was brilliant. That was amazing that we could see that in the neuroquant. Incredible. I really just can't, tell you how, we thought, and we were wrong. God knows we've been wrong. As data comes in and we sort of, learn more, we thought the changes that were occurring were exclusive to the neuroinflammation, sort of tied in some ways to the visual test. We thought that must be the reason why the brain is changing. We're seeing areas of growth or atrophy. We were wrong. Turns out the answer was in the genomics, and it's not driven by the inflammation. I'm going to hold you there and say, okay, we're going to, I'll let you know where, when we get to the transcriptomic talk, what actually injures the brain. It's fascinating. So we saw that there was a pattern of injury for water damage building, certain areas increase in size and certain areas decrease in size. And the same is true for Lyme, but a different pattern. Incredible. We never realized that. So now we had another tool. So yes, you have regular Lyme tests, right? Number one, you have the C3A, number two, and now you have neuroquant, number three, and I'm going to show you transcriptomics, a very powerful number four way to test. So for CIRS, once you see it as a practitioner, your life will be changed forever. If you start doing the visual test, symptom scale, if you're able to run some of these markers and they begin to come back abnormal, you won't believe it. You're going to say, I just, they're everywhere. I see these patients all day long. And it's going to fundamentally change your practice. I promise. But it's a language and an approach, and it's a deep understanding of, oh my gosh, it's a biotoxin exposure that ignites the innate immune system, and there's poor antigen presentation, and they remain stuck, and then the genomics alter, and the mitochondria change, and now they're in CDR1, CDR2, and sort of phenotypically they're triad 2, triad 4, they're sort of gut immune brain and poor detoxifiers, and they get all these other symptoms and problems. And guess what? When I try and change their diet and I give them nutrients and balance their hormones and have them do mind body skills and all, they don't get better. Why? Because there's deeper work that you need to do, and I'm going to show you how to do that. But here are the treatment challenges. First, eliminate the exposure. So if it's a microbe growing in the home, got to deal with it. If it's an infection, got to deal with it. A lot of these are self-limiting. Once the process starts, it just kind of keeps running out of control. So you have to first kind of figure out, is it still there? That's issue number one. Number two, you have to correct the inflammatory response, right? Like, you have to get the proteomics back to normal. You got to see resolution of the visual test. You got to see normalization of all the blood work. But remember, even though they might be feeling better, they're not all the way there, because you haven't really fully restored them back to normal, because there's going to be some abnormal genomic activity that has to be addressed. And the body won't fully heal and repair if we don't fix the genomics. The brain won't heal, the nervous system won't heal until we do that. And I'll show you how we get there. There's an order and a stepwise process. So when we put into the context of triad 2, that gut immune brain, here are a bunch of different labs that I think about that are sort of organized by those related systems. So we can do regular blood markers. We can even measure diamine oxidase, which is an enzyme that aggregates along the gut lining that helps to break down histamine. We can measure lipopolysaccharides in the blood. We can measure MSH. Remember, it affects tight junctions. We can do food sensitivity testing, or acetaldehyde for some candida growth. On the immune side of the equation, we can do more standard inflammatory markers like CRP and SED-RIGHT. We can do the genomics, which I'm going to get into. We can do, autoimmune markers to rule out CIRS and rule in other diseases. We can find measurable toxins and viruses. We can look for some of those innate immune proteomics like the MMP9, the alternate complement system, TGF-beta1, and then also clotting factors like anticardiolipin antibodies, von Willebrand's factor, D-dimer. And for the brain, we can see alterations in cortisol patterns. We can see degradation of the blood-brain barrier with beta-2 microglobulin. We can see some predisposition to psychiatric issues with SNPs like MTHFR. We see alterations on MSH, VEGF, TGF-beta1C4 that all affect the brain, and then changes in our volumetric brain scan, meaning neuroquant, and the visual test, which is a direct measure of cytokine activation. Whew. See, oh my gosh. Well, just take it one step at a time. I always start in the order that I gave you. Visual tests and symptoms. Is it likely? Yes. Run some of the markers. They start ruling in CIRS. Great. And now you're off and running. So here are the treatment steps for CIRS. This is what's published in the literature. There are 2 randomized controlled trials that we've shown that guarantee or demonstrate that this process really does work in our CIRS population. You can go to Surviving Mold and look at all the practitioners that are certified in this, and they have written in great detail what each of these steps are. This is well published, easily found on the Surviving Mold website. Every step has a treatment associated with it. So there's a sort of a rationale to the order. There's a rationale to the treatments. This is very medical, though, not integrative, not anti-aging. It's very medicalized. This is otherwise known as the Shoemaker protocol, who's my research partner. And this has sort of been worked out. What I have found, though, is that when you investigate these steps, I always ask the question, if I'm still going to maintain the order, but go a little further, can I do even better? Can I do a little bit more with this step? And the answer is yes. So I have a sort of a reorganized treatment process. Now, when you scratch the surface of this, so don't get overwhelmed by the detail of it, because we're going to have a whole other lecture on treatment. I'm going to go through all of this in incredible detail. But with that being said, um, when you scratch the surface of this, this is there. Okay. So I still do this. I'm still a purist in that regard. I still follow the integrity of the underlying protocol because it's what's established, it's a guideline. With that being said, I think we can expand. I think we have certain treatment choices, either to augment or even substitute at different steps of the process. So this is what I'm going to teach you, which is sort of the integrative version of the CIRS protocol. Okay, so we're going to really get into great detail. It also opens up all sorts of interesting opportunities for treatment beyond what the standard is. So thank you so much for your time. Hopefully this was helpful as an introduction to the topic. Remember, there's a first portion of this video 1, and then this is the second video. All right, so I'll see you at our next talk.